Recording in progress.
So I'll just let you put that on and bring it up.
Oh, nice production.
Yeah.
Oh, I guess so,
So when you come up, you just want to so it's on standby. And then we'll also hook you up with that one. So where are we going to put this? You know what? This one I can Good. That's good. I'm just going to put this one here. This one picks up better than that one. See, I hit that thing and it's still off.
Good morning, everyone. Good morning, everyone. We're going to get started with our first speaker here. I want to alert you that the back of your badge has all your Wi-Fi instructions, so if you pick it up and take a look at it, it'll answer a lot of your questions. If you do have questions, Jennifer will be available later for you. Please silence your cell phones, and if you're not feeling well, please take advantage of our online options. Our first speaker today is Sonia Hasbun, DO from St. Alphonsus Medical Group, Heart Care, Cardio-Oncology, and Women's Health. Dr. Hasbun is proud to be an osteopathic physician. True to her training, she strongly believes in treating the whole person and addressing the underlying cause instead of only focusing on treating symptoms. She is passionate about all facets of cardiovascular health, whether it be healthy, preventative lifestyle changes, in-hospital care, or chronic disease management. She graduated from the Arizona College of Osteopathic Medicine in Midwestern University in Phoenix. She completed internal medicine residency in Verde Valley Medical Center in northern Arizona, where she also served as chief resident. She finished her cardiology fellowship at Good Sam Regional Medical Center in Corvallis, where she also served as a chief fellow. Dr. Hasbun relocated to Boise in 2021 to practice general and women's cardiology in the Women's Heart Center at the St. Alphonsus Heart Institute. She sees both male and female patients in inpatient and clinic settings, and also travels to see patients in Nampa. In her spare time, she enjoys cooking with her husband, hiking with her dog, riding her bike, and maintaining her chocolate addiction. Today, Dr. Hasbun will present to us on cardio-oncology and women's health. Welcome, Dr. Hasbun.
Thank you, everyone. Can you hear me okay? If there's feedback from this, let me know. I guess we have 2 microphones, so we're juggling. So thank you so much for being here. Thank you so much for having me. It warms my heart that you all are willing to wake up so early to talk about cardiology, which is a passion of mine. So I'm hoping to cover a lot of things that will empower you in your practice. My understanding is that a lot of you are in our community serving as internal medicine and family practice. Is that correct? We've got some emergency medicine and hospitalist as well. So I tried to cover a broad number of topics to, again, empower you in your practice and the variety of people that you'll see. So I don't have any financial disclosures. This is me, that's my husband, and our little dog Rafi is a little Chihuahua Basenji mix. Has this started, the timer? I don't know if it's going. You'll let me know if I'm running over time. I want to make sure we have enough time for questions at the end, so we'll make sure we stay on time. Yeah, like she mentioned, thank you for that lovely introduction. Relocated here about 1.5 years ago from Oregon, and we're currently loving being in this beautiful state of Idaho. I do practice at St. Alphonsus as a general cardiologist, as well as a focus in women's health in the Women's Heart Center there with my colleague, Dr. Beth Molaski, who actually just retired. So very happy to be here to explain some of the things that I've learned along my journey in training and in the last 1.5 years of practice as an attending. And so I really want to focus on the prevalence of cardiovascular disease in women, identify common and uncommon presentations of cardiovascular disease in women, and then also wanted to talk a little bit about cardio-oncology and your role, because I think that term is starting to be floating around in literature, and you may be wondering, well, I'm neither a cardiologist nor an oncologist, so why should I really care? And so that's what I wanted to go over today, so that we can talk about some of the things that you can do, because I think you play a very important role in this new field that we're discovering more and more about. So why focus on cardiovascular disease? I'm going to skim over some of these slides. Some of this I think you already know. This is a couple of graphs from an article published actually annually as Heart Disease and Stroke Statistics, as you can see down in the bottom left, in circulation, that the AHA and the ACC collaborate on. To keep this slide simplified, I've just included that little logo as I pull things from this article you can see going forward. But as we can tell, that the cost of cardiovascular disease in the US is immense, right? It's very expensive. It's one of the primary causes for hospitalization. And so there's really an important aspect to that aspect of healthcare. If we look at that same article in circulation, we can see that deaths had steadily been increasing from cardiovascular disease in the 80s, and then started declining, and we start seeing a rise again in the late 2010s. And there are a number of explanations for this. There were better healthcare, public health initiatives and medications. We also started reporting things differently. So we're working on collecting better data to better understand how we're doing here in the US treating cardiovascular disease. I wanted to include this slide just so that we could see how Idaho's doing with the rest of the country when we look at age-adjusted death rates by state for cardiovascular disease, both for coronary heart disease in that second slide, and then stroke. Obviously, I'm a cardiologist, so we'll be focusing more on the heart aspect of things, but you can see that we're maybe not doing too bad, but I'd like to see us in the red where it's less often. So we have always room for improvement and education for our patients. And I think that this is something that we already all know and feel, but recently there was a statistic coming out that within Idaho, we're ranking last in the nation for active PCPs, near last for just all physicians in the nation in terms of per population 100,000. So there's a great need. You're touching maybe one or two people, but any education that you can provide for that one person extending into that family that they may or may not have a primary care physician yet. And so I'm really hoping that we can improve that in the future. But in the meantime, again, going forward with education, I think is very, very important. So the graph here on the left-hand side shows CVD or cardiovascular disease ranking with a number of other causes of death in this country. So won't move my head. So you can see I tried to circle for you there, drawing your attention, the role of cardiovascular disease, right? And again, some of this is redundant, some of this you already know, we already know, but I don't know that our patients know this yet, and we'll get into that in a moment. But basically, cardiovascular disease is the primary leading cause of death and morbidity and mortality in our country. But I think amongst women, they may not know that. And there has been a great public health campaign in the breast cancer awareness realm of things. And while that is very important, I think there are a lot of women out there that still are under the impression they're more likely to pass from cancer than cardiovascular disease. And so there is an opportunity for education there. There was an interesting survey that started being sent out in 1997 asking, well, are you aware of the risk of cardiovascular disease in women? And 30% of them identified heart disease as a leading cause. And you can see through the years in 2003 and then to 2012 that was improving. And so that the Go Red for Women Health Initiative has increased awareness, but then we start seeing also a dip as time goes on. And so maybe we kind of slacked off or assumed, okay, people already know this, I don't need to talk about this anymore. But I think that there is still very much a role, and we can see that amongst certain ethnic populations as well, there's a need for more education, letting people know that, hey, you are at risk and it's important to be aware of your symptoms. And so that's why a lot of what we're talking about today, I want this to be on the forefront of your mind so that you can have that on your differential diagnosis, because your patient may not offer their symptoms in a way that they recognize as heart disease. So again, some quick going over statistics about why this is important. There was a study done looking at women being less likely to receive bystander CPR, and it was a survey asking after out of hospital cardiac arrest, well, why didn't you give this person CPR? There are some perceptions that perhaps maybe increased litigation or risk of touching somebody without asking their consent. Maybe it's just better not to do anything. Maybe I didn't want to hurt her, she seemed weaker, I didn't want to break any bones. And then misconceptions about women in acute medical distress. Well, I thought she was having a panic attack. I didn't know if it was really real. So women are at risk. And then this is a busy slide. I've added some arrows here, and you can go back and read in your free time, but essentially looking at that there are still gender discrepancies even amongst healthcare providers in the healthcare that we provide, even though we strive to give equal care. It's the recognition. So even within cardiology, there are lower rates of certain medications prescribed between men and women, lower recognition of acute need to go to the cath lab. And so that's a metric that we call door to balloon time. So again, really needing to be aware that there are some discrepancies. So we've made a lot of progress in terms of mortality trends for both women and men in the US, and I think that that's something to be proud of. It's not all bad. I don't mean to be all doom and gloom, but just trying to show the need and show the areas where we have room for improvement. So as our understanding of cardiovascular disease in women evolves, hopefully we see those trends continue to improve. So cardiovascular disease prevalence is still male dominated. There is still a difference in presentation, right? So when we talk about premature coronary artery disease, it tends to be in men less than 55 and women less than 65. So there is as the population gets older, these numbers start evening out a little bit, you can see, but it is still male predominant. So I still do practice male cardiology, and that is important. So a lot of these things that we're talking about today can still apply to males as well. So I want to touch base for my OB-GYN colleagues here. there's a lot of emerging data suggesting that pregnancy may be the female's first stress test. And I bring this up because you may see this before they're at an age where they may be complaining of chest pain, but you're caring for these people that have had preeclampsia or gestational hypertension or perhaps gestational diabetes, looking at how big was their baby, where did they go into preterm labor, did they have placental abruption. All of these are starting to look at, is there endothelial dysfunction or some type of mechanism there that we'll see later as it plays a role in cardiovascular disease. So as we're taking a good history, we learn in medical school the importance of asking women about their reproductive health, but this is why. And I think that we can be more aggressive about treating women in their 40s that maybe come with a borderline LDL, and maybe you wouldn't be too aggressive about starting a statin, except for you look back and you see their pregnancy history and you go, that didn't go so well for you. And maybe in 10, 20 years, we're gonna see you present with an MI. What can we do to be aggressive about risk factor modification now? Here is a schematic, again, just looking at adverse pregnancy outcomes and risk of ischemic heart disease, and you can see with preeclampsia, hypertension, gestational diabetes, that there is a link there. Again, focusing on pregnancy and patients that you may see pre or post, or again, having had in their past, there's this concept of pericardium cardiomyopathy, which can be diagnosed anywhere after 36 weeks of gestation up to 5 months postpartum. So for our emergency medicine colleagues, you have a patient coming in, she's a younger female complaining of heart failure type symptoms, and you're like, well, you don't really fit the bill. Make sure you're asking, about pregnancy history, at least briefly, if there's any signs of them having mentioned that they've been pregnant, even with up to a year later. Something to be aware of. So we define it as an ejection fraction of less than 45%. The etiology is not quite clear, but we think that there's a link with prolactin, which I've got a schematic in following slides. So breastfeeding mothers, they may be far enough out from the delivery that stress has resolved, if you will, but there's still a role of prolactin while they're breastfeeding. There is increased risk in patients with African descent, advanced maternal age, and anyone that had pregnancy-related hypertensive disorders. So this is, again, another busy slide, a lot of basic science on here. So I don't want to give PTSD back to med school of reminding slides, but really the important part of this slide is endothelial dysfunction there in the middle and different mechanisms that lead to myocardiocite apoptosis and death. So again, focusing on women, patients that you may be seeing in your practice who have these risk factors, things to be aware of. Autoimmune disease are patients with lupus and rheumatoid arthritis, systemic sclerosis, and PMR. These are patients that have high levels of inflammation throughout their entire body, but increased cell turnover, right? So if we think about, again, the pathophysiology of atherosclerosis and plaque formation, cell turnover is one of them. So these are patients that perhaps may or may not be on disease-modifying medications, but probably should be, if in part for decreasing cardiovascular risk, if they've had high levels of inflammation for 30, 40 years before I even meet them. In retrospect, you look back and say, well, is this a risk factor that we could have modified? And then we'll get into cardio-oncology later, but history of chest radiation, patients who've had breast cancer, or especially children who've had lymphoma or other malignancies where they've had radiation to the chest. That's something that we should be aware of. Of course, men can get breast cancer as well, but that's the majority are our female patients. And so radiation, especially left-sided chest radiation, has come a long way, but we still are seeing patients with the sequela of 30 years ago when we weren't as good at focusing the radiation beam away from the heart as much as possible. So these patients are at increased risk of coronary disease, especially like in the LAD that comes down the front of the heart, or some of the valves that are more forward facing. We're seeing these patients have valvular stenosis earlier. So you have 55-year-old female presenting, let's say she's in the ER in your office and she's complaining of pain, and you're looking at her going, well, this isn't kind of the 70-year-old male who's a longtime diabetic and smoker and that I'm maybe used to seeing or remember seeing, learning about in medical school. There are a lot of things to think about. I want to go over some of those things. I think a lot of us are aware of the idea that women can present differently. And I see a lot of patients that get referred to me for possible anginal equivalents. And so I can see that there is increased recognition within the community and that desire to identify these patients early. So I really want to commend those of you that are thinking about this, but there are still often patterns. So I wanted to help kind of clarify that while we tend to emphasize women can present differently, there are still patterns, and it's not just like well, my teeth itch sometimes, and that could be an anginal equivalent. So I think for the males, we would all recognize if someone comes in complaining of crushing substernal chest pain that's radiating down the arm or up to the teeth and associated with nausea and vomiting and diaphoresis or cold sweats, right? I think you all know that already. But women may have some, all, or none. I've had patients complain of right shoulder pain. I have some patients that complain of my teeth hurt, and some just have nausea, right? But they do tend to follow at least the pattern that you would expect of worse with exertion and better with rest. So again, keeping things and a wide differential, and I want to dive into some of the different etiologies of chest pain too, so that you can start getting a feel for why some may present differently than others. Okay, so this is just a brief refresher. I think you all know this, so I won't spend a lot of time on it, but when we think about maybe the classic med school definition, we all think of this, right? Okay, well, there's STEMI, there's NSTEMI, unstable angina. Where do my patients fit in here, right? Fourth universal definition of myocardial infarction, type 1 MI is an acute plaque rupture. Again, I think we've all seen variations of this slide of some degree of atherosclerosis and this acute inflammatory response. But there's a whole myriad of things in the type 2 MI, which is more of a supply-demand mismatch. And so I really want you to think about it in those terms when we talk about all of these different etiologies for chest pain, is well, how is the supply and what is the demand, and is there a mismatch there? So sometimes we'll see a rise in troponin. That's how we would technically define an MI, but we'll get into some of the nitty-gritty within the cardiovascular side of things of how are we defining MI really the way that we should. So in 2018, they added MINOCA, or MI with non-obstructive coronary artery disease. So on the hospital side of things, when someone comes in complaining of chest pain, maybe they have EKG changes, but they have elevated troponin, which now many of us have high sensitivity troponin, which is very, very sensitive. You joke around, sometimes you feel like if someone sneezes hard enough, it's going to be positive. So what do you do with that data? Does every single person need to go to the cath lab? Well, maybe not, but many of them do. And for those that do, perhaps we get in there and there's no obstructive disease. Maybe there's some non-obstructive plaque. Well, what do we do then? Where did this troponin come from? And there can be a lot of things. And so that's what some of the things I want to go over today, so that you're familiar, especially if some of your patients come and follow up and they say, well, they said they had a heart attack, but it was a small heart attack. Well, what does that mean, right? And they took me to the cath lab, but they didn't do anything. They just said I need medication. And well, what does that mean? Was a stent not feasible? Was it too small of a vessel and we don't make stents that small? Did they really truly see nothing? Did we just totally clear arteries? When does that happen? Not that often, right? So that's where we are starting to define things better. And so some of these patients, while they may not come describing these terms, this is what your patient's coming back with, a diagnosis. And so I hope that as you're reading our notes, this talk can help you recognize what some of these acronyms are for. So we talked about acute plaque rupture, but it doesn't necessarily have to include the lumen. SCAD, or spontaneous coronary artery dissection, we'll talk about coronary artery vasospasm, microvascular dysfunction, thrombosis from a hypercoagulable state, and stress-induced cardiomyopathy. So SCAD is a newly evolving, not that well understood, although we're getting better at it, etiology of essentially it's a dissection like we would think of in the ascending aorta when you think about really bad aortic dissections, but that can happen in a coronary artery and it can happen spontaneously. And it often presents as a STEMI. It's an acute ST elevation MI. This patient looks the way you would expect. She's clutching her chest. She's sweating. She does not look good. She's kind of gray. And you're like, let's go to the cath lab. Surely we're going to have to stent this, right? And so we got in there. I've got a picture here. We got in there and this is what we see, right? It's just this little string of an artery. It's holding on like a bare thread. And you can see that proximally, do I have a pointer? Can you see this? Okay. So proximally, the artery's normal, and then you can see this tiny little lumen, and then down here distally it's normal. And so that looks different than what we would see in a focal area of atherosclerosis. And so sometimes we see this and we go, okay, this person has coronary artery dissection, and that can account for up to 4% of acute MI. More commonly occurs in women. It's more often in younger women and not uncommon in those who are pregnant or postpartum. Again, going back to endothelial dysfunction, we suspect there is a hormonal relationship there. And there does seem to be a very strong correlation with fibromuscular dysplasia. And up to 50 to 70% of SCAD patients may have FMD. There are other risk factors like vascular connective tissue disorders, hypertension, migraine headaches, and history of preeclampsia. So this can be a very difficult thing to manage because we often tend to just leave it alone. If we can get their blood pressure under control and we can get their EKG changes to come down, we'll often walk away, which can be hard to do. You want to fix it, but there's a pretty big risk of putting a wire down that artery, and you can go down into the false lumen and propagate that false lumen further. But these women will present like an acute MI and will have sequela. I just had a patient last week who has apical akinesis because of this. She had SCAD in her LAD. So we treated her with nitro and beta blockers. We did give her aspirin and Plavix. We didn't give her heparin because we worry about that intramural hematoma propagating further. But we treat them conservatively, if you will. But these women have some sense of PTSD, if you will, afterwards, wondering, well, is this going to happen again? When might it happen? There's kind of that sense of waiting for the other shoe to drop. And so there is definitely a psychosocial component as well of explaining to that 43-year-old patient that doesn't have any friends her age in her cohort that she feels really understands her and what she's been through. And she's going to cardiac rehab and everybody else there has silver hair and she doesn't really feel very well understood. And so these are people that there weren't the time saying, I see you, this is real, and helping them work through that. So something else that we're starting to learn more about and is more common is coronary artery vasospasm. And this is also something similar. I've got pictures similar where you watch the lumen go from normal to not normal, but it's not acute plaque rupture. It's a spasm, and it can often be secondary to some type of trigger, right? So whether it be endogenous or exogenous vasoconstriction, there are any number of things, but for women that have MI with non-occlusive coronary artery disease, many of them have coronary artery vasospasm. And the key to this is it often happens at night. So a lot of times when I'm asking people to characterize their pain, if you can ask them, well, what time of day does this tend to happen? A lot of these women will say, well, I start getting it at night before I'm getting ready for bed, or it'll wake me up from sleep. And so we think that there's some type of diurnal pattern. Can be associated with EKG changes, but not always. And something that's really cool about recent discoveries is that we've got something called coronary artery vasoreactivity testing. Not all studies or not all hospitals do it. We actually do it at St. Al's. And so you can take them to the cath lab and inject acetylcholine, and you're looking for an area of spasm. So if you can see on the baseline here, there's perhaps a little bit of plaque there. You can see where the lumen's 100%, and maybe this would be like a 10 to 30% plaque. This is baseline, and you give them ACH and it spasms, and they have the same, and they go, oh, that's what I'm feeling, right? They're awake in the cath lab, and we ask them, how are you feeling? And we're watching for EKG changes. And so to be diagnostic, you see EKG changes, and they go, this is exactly what I've been feeling. And so you give them nitro then, which is in the bottom left-hand corner, and you can see that it vasodilates. And so I think that this is a very new and evolving technique that we're getting better at. It's extremely important for those of my patients who feel like they've just been told this is all in their head. A lot of people for many years have been like, well, maybe you're just anxious. Maybe we just prescribe you a benzo or an SSRI. And some of my patients come to me and they say, I have anxiety. I know what that feels like, and this feels different. So there's a little bit of, sometimes they feel like medical gaslighting where they weren't taken seriously. And so not everyone needs this, but for those that you're really struggling to maybe make the diagnosis, or they're really struggling to feel like, well, is this real or is this all in my head? I've had a number of patients where it's a great relief to them to see the pictures and they go, okay, I'm not just making this up, this is real, and now we can go forward and really focusing on managing it. In addition to not only managing their current day symptoms, we all also recognize that this is a predisposing risk factor for maybe more traditional coronary artery disease as you would think. So this is a good example of here, 3.5 years later, this person now has a much higher grade stenosis in that artery than they did here. So risk factor modification as well. Microvascular disease, I think I have here. This is one of my favorite pictures of the heart. When I think about the heart, this is often what I think about. I think we often remember these from med school when you maybe shadowed a cardiologist in the cath lab. And these are your epicardial vessels, and they're quite large, and if there's a big stenosis here, then we can stent that. And that's very satisfying to see that get bigger, but how many more blood vessels do we have that we will never have a stent small enough to open that up? And so when you're talking to patients and they're complaining of chest pain, think of these tiny little vessels, and do they have a tiny little vessel that's smarting that we'll never see, and they don't feel validated because we can't see it on coronary angiogram, but we see this here. And so cardiac MRI and PET are two modalities that are gaining more traction, and we're using more and able to see more on maybe a more microscopic level of being able to identify these patients that do have true ischemia. It's just not something that we can see in the lab, but we treat them nonetheless the same. So shifting a little bit in terms of things that can cause chest pain in women but aren't vascular occlusions is stress-induced cardiomyopathy, also known as Takotsubo cardiomyopathy or broken heart syndrome. It accounts for up to about 2% of acute coronary syndrome cases because they can have a troponin leak. It is a diagnosis of exclusion. A lot of times we'll see the characteristic findings, which I'll show in a couple slides. We'll see those findings on echo and we suspect it. Perhaps we get a good history saying, yeah, my chest pain started right as my son called and said he'd been in a car accident and he's on his way to the hospital, or whatever that large catecholamine surge is. But we still do take them to the cath lab and often look, because sometimes the apical ballooning can mimic a large LAD lesion, and that's not something we would want to miss. But in your patients where you think maybe keeping an open mind differential, maybe they come to you first saying, last week I had this. It does tend to be in older postmenopausal women, and like I said, is associated with some type of emotional or physical stress. I've seen it in patients undergoing chemo or really grappling with different diagnoses. Like I said, accompanied by troponin and EKG changes, and I think I mentioned the catecholamine surge. So these are a series of EKGs that I took on one of my patients, that this was her baseline, and then you can see here she has pretty deep T waves across the precordium, and she came in complaining of chest pain. She had come in for, I think it was like a dialysis port or something that should have just been kind of a routine outpatient procedure, but she had gotten really anxious about it, and so the process of everything leading up and then the actual procedure, the procedure went well, but then post-procedure complaining of chest pain. So this was the middle EKG was when I met her, and then this is the follow-up EKG several days later, actually, after we had diagnosed her with Takotsubo. So it's named after this Japanese octopus pot because of the shape. And this is on the left-hand side, this is a left ventriculogram that we don't really do that much in the cath lab anymore because echo has come so far and we've got better modalities. But you can see that when the base contracts, it comes in, and the distal apical segments just don't move. And so you see this kind of ballooning pot type, very classic echo finding. So standard of care is to rule out obstructive coronary disease, like I mentioned, and then conservative management. So these patients will come back to you, hopefully, if we've done our job correctly, on a beta blocker, or an ACE or NARB, aspirin, and dual antiplatelet therapy if they've had a significant troponin leak. And really the most important thing in addition to medical management is stress management as well, because we have seen recurrence happen. And then within a couple of months, these do tend to get better. So we tend to recheck an echo and we see that those wall motion abnormalities improve. So I did want to touch on also something called angina with no obstructive coronary artery disease. So we have MI, which is MINOCA, and then angina without the occlusive coronary disease. And so we talked a little bit about that microvascular angina, vasospastic angina, but keep in mind too, severe aortic stenosis can cause chest pain, myocarditis and pericarditis can cause chest pain, and certain arrhythmias. So keep your differential broad, and then I would be remiss to not at least honorably mention non-cardiac causes of chest pain, right? Of course, that's my bias, is cardiac chest pain, but aortic dissection and PE can cause it. There are obviously many musculoskeletal reasons. I've seen my fair share of patients who've been referred to me, and by the time they make it to me, we can see their shingles rash, but the referring provider couldn't. So keep that on your differential, that sometimes that may be the cause of their chest discomfort. GERD, hiatal hernia, esophageal spasm. There are a number of other reasons why people can have pain here in this region, and we all associate it to chest pain related to cardiac causes, and of course that's not something we'd want to miss, but maybe something that you could work up in the meantime while you've sent the referral, and by the time I see them, they can say, these are all the things we've tried and it's not getting better, and then that gives me a direction in which to go. So honorable mention for palpitations. I think a lot of us see this. It's a very common complaint. I don't have a whole lot of time to go into all of it, so I'm going to breeze over some of it, but people can have pain with palpitations as well. And so I think it becomes this dubious, like, well, how scary is this? Is this cardiac? Is it not cardiac? Is it supraventricular or more ventricular? Is it potentially deadly or not? And is there increased risk of stroke or not? So those are some frameworks that you can think about if someone comes to you with complaints of palpitations and you start going down the differential diagnosis in your own mind. Again, we don't have a whole lot of time to go through this. I want to focus on some other things, so I hope that you have some time to read through these slides, some light-free reading today. But just to mention or touch on that the supraventricular tachycardia is more common in women, and so that's why you may see more of your female patients complaining of palpitations. I think that there's a term sometimes that people use as like heart awareness, which again kind of carries the connotation of like, well, you're just really sensitive, but you know, maybe she is, maybe she isn't, and so keep that in mind. It may be an arrhythmia. And then again, this could be its own talk, and something that I see often in my clinic as well, something called autonomic dysfunction or dysautonomia that may present as palpitations, and it's not an actual arrhythmia. They're in sinus rhythm, but they're having symptoms from it, and it's because they're tachycardic inappropriately so, either because there's a postural component, it's not just straightforward orthostatic hypotension, but that I always often tell patients that, you know, your heart rate and blood pressure are kind of like a teeter-totter. So if your blood pressure goes down and your heart rate goes up too much so and is overcompensating, a lot of patients may feel symptoms from that. And inappropriate sinus tachycardia, you're just going faster than you need to. So these patients can be very difficult to comb through what exactly is going on, because there can be myriad of symptoms and they tend to be very vague of like, well, I just can't function, I have brain fog, I'm tired, I try and exercise, I can't, and you're like, you're 26, why not? Like, just get on the treadmill, start walking more. But for some of these patients, it really can be debilitating. So keep this again in the back of your mind. I'm happy to see them for this. It can be a very challenging diagnosis. There are a number of comorbidities that I've listed there on the bottom of the slide, hoping to try and give you some triggering things. Patients who have Ehlers-Danlos or a number of GI issues. MCAS stands for mast cell activation syndrome, which is debated in some areas of allergy immunology, but patients with TBIs and certain psychiatric diagnoses, again, may feel things differently, and so it's really, I think, on us to kind of parse through what they're feeling and interpret what that may be. Okay, again, going to breeze through some of these things because some of them you already know. I wanted to create a somewhat comprehensive review, but I've put asterisks next to the things that your female patients may be more often to have, obviously pregnancy, but anemia, hyperthyroidism, certain weight loss supplements can cause more palpitations or chest discomfort, obviously, and there are a number of substance abuse disorders that can play a role, and then different medications can cause palpitations. Okay, so getting into treatment. Okay, thank you for all of that information. Now what do I do about it, right? Not all of them have to come to me. I'm happy to see them, but I want us to be able to work together. And so going back to the need for more doctors and the need for more education, we call it life simple sevens. It's much easier said than done. I often tell people, I know you've heard this before, but we're going to go over this again because it really does work. And so I think it is very important to instill early the importance of being aware of what you're eating, what you're putting in your body, how much are you moving in a day, what is your healthy weight, what should a goal be, having these conversations and avoiding tobacco products. All of those things are still just as important as they were when we learned them in med school. So I do spend a lot of time educating my patients, and I think that it's important, especially not to be stereotypical, but a lot of women are the people cooking for the family. So if you can educate them about what's important to cook, then hopefully that translates to healthy habits for the entire family. MyFitnessPal is an app, not sponsored, but it's a free app that I often tell my patients about, that it will scan barcodes, and so it really can help them keep track of their macros and their calories. And for those of my patients that I want them eating a low sodium diet, it will help calculate how much sodium. And so I think some people mean well, but my favorite example is, well, I'm going to have a healthy snack and I'm going to eat a handful of nuts. A lot of people don't realize how many calories are in nuts, so we emphasize we want you getting your healthy fats from nuts and avocados and olive oil, and so they're like, okay, I'm gonna have nuts, and then they don't realize they're eating 1,000 calories a day in nuts. So they're wondering why they're not losing weight. So there is still a lot of room that we can take advantage of those healthy sevens. Again, some of these things we will be starting. Patients may come back to you. These are things that you're obviously able to prescribe as well. So not underestimating the power of the baby aspirin. 81 milligrams is all they need from a cardiac perspective for atherosclerosis treatment. Heparin we use a lot in the acute setting. Beta blockers or calcium channel blockers, depending on different comorbidities. We use ACEs and ARBs often. Statins for cholesterol management. Nitrates, there can be short-acting and long-acting. So the short-acting under your tongue, they can take as needed, and long-acting isosorbide mononitrate also goes by Imdur, which is the brand name, and that's taken once a day and helps keep pain away. So we use Imdur and Renexa or ranolazine, which is the next one down. Those are both vasodilators and antispasmodics and play a very important role, especially in patients with vasospastic angina or small vessel disease that we can't get to. And then again, regular exercise, cardiac rehab, it's amazing how much people's functional status can improve. It's all about supply and demand mismatch and really teaching the body how to be as efficient as possible with the blood supply and the oxygen supply that it has. So I want to wrap up. We've got about 4 minutes left, and I want to leave a lot of time for questions. What exactly is cardio-oncology, right? So I've included the official definition from the American College of Cardiology on the screen. It is emerging, it's multidisciplinary, and it focuses on cardiovascular management, prevention, diagnosis, and treatment of patients with cancer. And the core objective is to make sure that the cancer patient of today doesn't become the heart patient of tomorrow. And I'll have an example that I'll mention here in a moment that I saw personally recently. And so those include patients currently undergoing treatment. We see a lot of people on chemo that we're following their echocardiogram to monitor cardiac function, but also those who've been treated for malignancy in the past. So I recently saw a patient, she was 27 years old, she has a past medical history of neuroblastoma in childhood, and she had chemo and radiation back when she was a kiddo. And I was fortunate enough that the facility that she went to kept really good records, and so I was actually able to get records from the early 2000s. And so I'm reading through this after I've met her. She came seeking repeat pregnancy, and she has this history of pericardial cardiomyopathy, and she says, I want to get pregnant again. And I see this in her history, and I go, well, let's just kind of see what you had for chemo and radiation, and there it is. Doxorubicin, we all recognize that. What do they call it? The red devil, right? Cyclophosphamide, etoposide, cisplatin, carboplatin. This is just this whole string of things that makes my heart hurt, right? I'm like, oh gosh, here's this person who she's already had pericardium cardiomyopathy. I'm looking at her of a lens of worried about repeat pericardium cardiomyopathy, and this is a heart that probably was at risk long before she even got pregnant, and then she had preeclampsia during her first pregnancy, and that probably then further contributed. So you can see this emerging theme of in a 27-year-old who she feels like she's healthy and she's chasing around her little 3-year-old now, but I see a very different picture when I look at her heart and going forward, thinking about her in 30, 40 years. What can we do now to help her heart now? So the patients that are most at risk are those who've had chest radiation, like I mentioned before, those with a history of breast cancer, lung cancer, lymphoma, increased risk of cardiomyopathy, premature coronary disease, valvular stenosis, like we mentioned before, pericarditis, any inflammation of that pericardial lining, and arrhythmia as well. And we talked about some of the chemotherapy agents that my patient had. So just as a brief refresher on the most cardiotoxic chemotherapies that you may see your patients having as current day treatment or previously, doxorubicin and epirubicin are the worst because they increase risk for heart failure not only while they're receiving it, but it can be even decades later. It does tend to be dose dependent, and the oncologists are much more aware of that now than they used to be, and so we see a lot of combo regimens where they try not to give too much, but you'll definitely see patients with that in their history if you're fortunate enough to be able to go get those records. HER2 targeted therapy like trastuzumab have increased risk of heart failure and 5FU or kappa, whatever that one is. I'm not an oncologist. Increased risk of MI and arrhythmia. So some of these, especially the breast cancer therapies, they're taking that for years after, right? So something to, again, be cognizant of. So if you're not the cardiologist and you're not the oncologist, you still play an incredibly important role, including screening these patients, taking an excellent history. We rely so much on your records keeping. I don't know if you realize it's just like a true gold mine when we get a referral, just going through somebody's history. All of your hard work, staying up late writing those notes, they really are important. And so you feel like those tidbits of things where you're like, well, maybe I just want to include this history, I just want to get this note done. But if it can be carried forward and we can see what they received in the past, that can really be so immensely helpful, especially if those patients are lost to follow-up decades later. So often their oncologist will see them. There are some like child survivor cancer programs where into adulthood they'll continue to monitor them, but a lot of times they move away, right? They go to college, you know, where life takes you. And so they're like, well, yeah, 20 years ago I had this thing. Maybe my mom could tell you what I had, but I don't know. So if you can get those records or keep those records going, then that can be very helpful. And then just keeping in mind their oncologic history, like I mentioned, that patient of mine who I saw for something completely different, but then in reviewing her history, I realized that it was probably a bigger issue. So in conclusion, takeaway points: women with cardiovascular disease can present with myriad of symptoms, and they don't always follow the textbook description, though they certainly can. There are many reasons why women can have chest pain. Some of them are cardiac, many of them are cardiac, but some aren't. And just because a woman doesn't have obstructive coronary artery disease doesn't mean she doesn't have heart disease. By perhaps the classic definition, as you've seen, that definition is much wider than it used to be. Primary care providers play a very important role in identifying those at risk, especially those who've had previous malignancy. And of course, when in doubt, we're always here. Feel free to refer to cardiology. We're happy to help any way we can. Does anybody have any questions?
Thank you, Dr. I'll go ahead and hand the mic to anyone who has a question.
Can you comment on when the cardiac calcium score would be indicated?
That's a great question.
Can you repeat that for the
Oh yeah, thanks for the online audience. Thanks for the reminder. The question is, when should we get a cardiac calcium score? Well, I'll start with the last great thing about it is a lot of times insurance won't pay for it. So that's why you see me kind of grimace and hesitate. I think I hope that we can get it paid for sooner, because I think that it does play a very important role. The way that I use it right now is really people on the fence that maybe you're recommending a statin and you say, I see these risk factors, maybe your lipids aren't ideal, and they're like, well, they're not that bad. I looked it online and they're not that bad. Sometimes I'll use it as well, yeah, but I think you have coronary disease. It's just probably not obstructive yet and you're asymptomatic. So that's a lot of times where I'll get the coronary calcium score, because it'll stratify for their age, how much coronary calcium they have. What I'll also throw in there is, we see that a lot incidentally, even just regular chest CTs, right? You get that back and maybe they're having lung cancer screening, or they were in the ER and they got a CT scan and you see coronary artery calcification now and you're like, well, should I send them to the cardiologist? And so I think that is I do put it in their problem list. I think there is actually an ICD-10 for coronary calcium incidentally found on CT scan. And if they're really, what it boils down to is what does their EKG look like and are they having symptoms? So going back to the Life Simple Sevens, a lot of times when I talk to people about the importance of exercise, it's not just the cardiovascular benefit, but the analogy I give them, I said, there's a really big difference between you saying, don't worry, doc, I never have chest pain, but they have a desk job and then they leave their desk job and they come home and they watch TV all night. There's a big difference between that person and somebody else that's out running the trails in Boise, or they're riding their Peloton a couple times a week and they're like, don't worry, doc, I'm not having chest pain. And so I tell people, if you can get in the habit of movement, not only is it good for your heart, but we're going to see things sooner. And so that's really the role of the treadmill. The stress test is if that person isn't already doing it themselves, then you can really put it to the test. So it's really, there is some gestalt there, but I tend to be more conservative myself if it's just coronary calcium. I think you could make an argument for aspirin, and then definitely a statin and blood pressure management and diabetes control and those other things.
Thanks for the presentation.
Yeah.
I have a question. One thing I struggle with a little bit is some of these non-obstructive coronary artery disease states that you've mentioned. Or, for example, I saw a CAT scan recently that showed some very, very mild atherosclerosis. Should all these patients be treated like someone that's had a heart attack? High-dose statins, aspirin, beta blocker, ACE inhibitor, things like that?
Yeah, the question is kind of twofold about for all of these patients who've had these types of subsets of MIs, and then people who have coronary calcium on a CT, should they all be treated as if they've had an MI? I suppose yes and no, in terms of, I think that you can treat them with aspirin and beta blocker. Those would be the first start, and statin, definitely especially based on their lipid profile. So you can treat them as if they have coronary disease, but pre-MI, right? We're all trying to prevent that MI, right? So that's where we start worrying about changes that we see on echo or long-term damage. So if we can be aggressive about it, I think that there is a role for that. And many of these patients, we do treat them as if they've had an MI. Does that answer your question?
I kind of had a couple follow-up questions to the first two. So I'd just like to hear your comment on aspirin. There's been a big shift in recommendations for aspirin over the last 14 months. A lot of people we were treating, and several groups are saying, don't put people on aspirin. But I'd like to hear from a cardiology standpoint on that. And then the second piece, HDL. There's a lot of newer data coming out of is HDL truly a risk reducer because of the functional versus non-functional HDL? And it seems to be fairly new, but I was going to see if you could give us your take on that. Okay, good.
So there are two questions. One about aspirin. When should we give it, or should we maybe be pulling people off? That's kind of what the gist I get of what is my current opinion on aspirin, and then current opinions on HDL and different types of HDL, and is it as cardioprotective as we've thought? So I think that those are really good questions. I do actually take some people off aspirin. I do tend to wait until I have a clear diagnosis of knowing that this is truly going to help everyone. I think, previously we thought, well, let's just give everybody a baby aspirin. What's the harm? And we do find now that for the incidental number of people that we help, there's probably the same number of people that we unintentionally increase their risk for gastritis and GI bleed. So I do tend to look for a diagnosis that is a clear indication for aspirin. I think for some of my older patients, if they're like in their 80s and they've got lots of risk factors, and you almost clearly know that they have coronary disease, or you can see that they've had a stroke or some other type of atherosclerosis equivalent. Obviously, stroke is a primary indication for aspirin as well. But we do have a conversation about that. Some of my older patients, they've been taking it forever, and it gives them comfort. And I'm like, well, if you're tolerating it, I suppose this is a shared clinical decision-making conversation if they want to continue it. But if they don't have an absolute clear indication, the waters get muddied when you start talking about like coronary artery vasospasm. Well, is that a true atherosclerotic event? Do they need to be on aspirin? There is some data to suggest that there probably is an increased risk of artery spasm near an area of non-occlusive plaque. So if we haven't gone in and haven't demonstrated it, then we're sort of presuming that that's there. So I think it's a less wide of an indication, but it's still appropriate for many. But there are some patients where I said, I don't, you're not having active chest pain and I don't have a clear diagnosis of coronary disease. So I'll take them off. As for HDL, is it as cardioprotective as we'd like to think? I guess the caveat will be that I'm not a lipidologist. There are some people that really get into the nitty gritty. I think we'll find out, I'm hoping in the next coming decades, not only just the type of HDL, but like particle size and even like Lp(a) and apoprotein B and all of these other different particles. And hopefully one day we can target those more specifically depending on what they have. I think that it's probably not as cardioprotective in the way that we'd like to think in terms of, well, your LDL is high, but your HDL is also high, so maybe we don't have to treat your LDL. We do tend to focus more on reducing that LDL and trying to optimize the HDL, which can be difficult to do, right? There's a very strong genetic factor. Statins don't really increase HDL that well. There is a role in diet and exercise that can help, but it's not a get out of jail free card by any means.
Okay, more questions?
I was just gonna ask what you counseled that patient on that pregnancy.
Oh, the peripartum that was a difficult conversation. Again, shared clinical decision making. I don't want to give away too much, I guess, because there are some specifics in the case I debated even sharing because there aren't that many people with neuroblastoma getting pregnant soon. But yeah, we had to have a very honest conversation of the possibility of recurrence of peripartum cardiomyopathy. When we look at pericardium cardiomyopathy, a lot of times we look at how well is their EF recovered. There's a pretty clear consensus they shouldn't get pregnant again if their EF is still less than 35%. There's a very strong risk of further worsening. If you're in that 40% to maybe 50%, you have increased risk, but some maybe. And then there's a risk, but we all feel most comfortable if we can get their LV function to totally recover. So in her case, she actually hasn't. I did a stress echo trying to mimic stress. And I mean, her systolic pressure went up to 200 and we could see wall motion abnormalities. So it's not advised. I told her we'll stick by you, but you need to know that there is definitely a risk of needing ECMO or heart transplant and urgent transfer to a transplant center. So we just had to have a very real conversation of you need to really think long and hard about what risk is that worth to you, because we don't have good numbers. We don't have any good randomized controlled trials. Nobody's going to sign up for that, right? So we just have the limited data that we have. So really just having to counsel patients on what their risk is and trying to modify that. So for her, it'll be very important that we work closely with OB-GYN and MFM to control her blood pressure. That's going to be our biggest plan. From a cardiac perspective, the lower the better. From the placental perspective, not so much. So we're going to have to be very careful and just monitor her closely, and we'll do regular echoes. And if we need to deliver early, we may have to do that, and then probably no breastfeeding because of that role with prolactin. We'll just put her on heart failure management pretty aggressively as soon as baby's delivered.
More questions?
Thank you for your nice talk.
You're welcome.
I work mostly in the ICU, so I see a ton of Takotsubo's cardiomyopathy.
Cool.
So I'm confused about the antiplatelet. Something you give most people with that? Aspirin, both?
It depends. Yeah, it depends on what the troponin is. Not necessarily, but there is a role for antiplatelet if their troponin's really high. If you feel like it's really been a pretty extensive MI, especially in that 1 to 2 month period. We don't do it as long. So for patients who we stent, the general recommendation is still 1 year. Our stents are getting better and better. So we're doing dual antiplatelet therapy for a shorter course, especially if forced. But in that type of scenario, if they have a significant troponin rise and significant myocardial injury, that's just from Takotsubo, you've ruled out obstructive coronary artery disease that we can see, right? But there's still that concern for more microvascular. So we may continue it for a couple of months, recheck the echo. If everything's normalized, then maybe take them off of it. Sorry, I didn't repeat the question. He was asking about, he's in the ICU, he was asking about Takotsubo and the need for dual antiplatelet therapy.
All right, and one last question for Dr. Hasbun.
So it's kind of a similar question, but for Menofat, with it without obstructive coronary artery disease, do you consider that, do you treat that as an NSTEMI and you utilize the platelets per year, or do you treat that as a demand ischemia?
Yeah, so the question's about MI with non-occlusive disease. Do you treat that as demand ischemia, or do you treat it as maybe more traditional MI and dual antiplatelet therapy for a year? Again, sometimes it's nuanced. By the book, yeah, everybody should be on dual antiplatelet therapy, but I always try and take into account the risk versus benefit. It's no small thing to ask someone to take that for a year. That's a long time. So I think sometimes it depends on what it is. If it's just spasm and you can work on not spasm, that's different than, again, a lot of times we'll use the troponin and the echo to guide us, or EKG changes, trying to look at the extent of how we think how much that MI is, or do a shorter course of dual antiplatelet therapy.
Very good, thank you.
Yeah, thank you, everybody.
All right, we've got our spinner winner. Before you depart here, prior to that, a couple of things in case you're just arriving. We are spinning for a $50 gift certificate after each 1 hour session. Have to be present to win. We are, after this, going to take a 15-minute break and restart at 8:30 with our next